We're going to begin the dermatology lecture with a discussion of bullous diseases, which are also called blistering diseases. They mean the same thing. And we're going to begin with pemphigus vulgaris. The slide up here also includes the words pemphigus vegetans, which is a rare variant of pemphigus vulgaris that I doubt you'll be responsible for, so we're not going to touch upon that. Pemphigus vulgaris is an autoimmune disease of the skin. Okay, patients who have pemphigus vulgaris have developed autoantibodies which respond to antigens that are found in the epidermis of their skin. It's important to remember that these antibodies are found in the epidermis, that is in the top layer of the skin. You know, the skin is composed of a top layer called the epidermis and a deeper layer called the dermis. And these antibodies very specifically are found in the intercellular spaces between epidermal cells. So, if you imagine that the antibodies attach to antigens in the intercellular space of the skin, you can then conceptualize that the skin, the epidermis specifically, no longer can stay intact, and it begins to break apart and blister up. Here we have a classic picture of pemphigus vulgaris. Now, it's a blistering disease, but if you look at this slide, you may see some intact blisters, for example, beneath her left breast, but most of the skin is actually denuded. The reason it's denuded is because the blisters are so superficial, they're way up in the epidermis, that by the time the patient presents to the physician, you very rarely see intact blisters. If you do see intact blisters, they're very fragile and easily breakable. And here we see another close-up. You can imagine that wherever you see one of these lesions, there was a very fragile blister which has broken apart or is in the process of breaking apart, and you can see the denuded areas. There are some intact blisters, especially down the middle of this picture. And here we see a close-up of a patient who presented just like this, where the blister was completely dried and all we saw was the crust. This disease involves not only the skin, but also the oral mucosa. And as a matter of fact, it very often presents with erosions in the oral mucosa before the skin is ever involved. It was a fatal disease before we discovered corticosteroids. Now we can treat it with high-dose prednisone and other cortisones to suppress the blisters, and we also use steroid-sparing medications like azathioprine, which allow these patients to survive. The thing that I think it's important for you to know is, while this is a classic picture of pemphigus vulgaris, there are many diseases that present looking very similarly to this. So if you should see a patient or a slide that looks like this, think of pemphigus, but remember, the real diagnosis is made by biopsy. And what you need to see is the epidermis breaking apart one cell from the other for the reasons we talked about, and also immunofluorescence can actually show the antibodies being deposited in little circles around the epidermal cells, and that's how you make the diagnosis. I just very briefly want to discuss two other forms of pemphigus. These are the superficial forms of pemphigus. This really is just for completeness' sake. These two forms of pemphigus are exactly the same in the sense that there are autoantibodies which react against antigens in the intercellular spaces of the epidermis, but they only react with very most superficial epidermal cells. So these blisters are even more superficial. And as a matter of fact, you almost never see an intact blister. All you see is scale. Okay, the next major topic is bullous pemphigoid. Bullous pemphigoid is also an autoimmune disease of the skin. In this case, The antibodies react against antigens that are found at the dermo-epidermal junction. Okay, they do not react with anything in the epidermis per se. The reaction is at the junction between the epidermis and the dermis. And as a result, the blisters are deeper. I think we need to bring the lights down a little bit to see some of these slides. In this slide, you can see both an intact, tense blister. There we go. And in addition, you can see some denuded, eroded areas. And this is very characteristic of bullous pemphigoid because, as I say, the blister is a little bit deeper. It occurs at the DE junction, and therefore the blisters are tougher. They tend to be tense and are often intact when we see them. Bullous pemphigoid presents in an older population than pemphigus. Pemphigus is classically seen in, say, 30s or 40s, but bullous pemphigoid is seen in a geriatric population, classically, very often in patients in their 70s or their 80s. Bullous pemphigoid usually does not involve the oral mucosa, and that's a good differentiating feature between bullous pemphigoid and pemphigus. Once again, though, here we have a nice picture of an intact bulla. Okay. Let's just go back to that. Once again, when these patients present, you have many little tricks to think bullous pemphigoid, older patient, tense blisters, but you don't know for sure until you do a biopsy. And on the biopsy, you see a blister with the epidermis, the entire epidermis, lifting up and separating from the dermis, because that's where the antibodies are attaching. And once again, on immunofluorescence, you will see lighting up at the DE junction. There will be a linear line at the DE junction, and that differentiates it from pemphigus. I just wanted to mention a variant of pemphigoid called cicatricial pemphigoid. I think that this is less important, but the reason I'm mentioning it is because both pemphigus and pemphigoid tend to heal very well once they're treated. If they're treated with prednisone or with steroid-sparing medications, they usually heal very nicely and the patients do well. They don't usually scar. There is a variant, however, of pemphigoid that does scar. And unfortunately, it's a variant that almost exclusively involves the mouth and the eyes. You may get a little bit of involvement in the skin, but with this rare variant of pemphigoid, we get scarring of the mouth, like you can see here, a scarred tongue. They often get scars around the mouth as well, and they can often suffer blindness from involvement of the eyes. Okay, I want to say a few words about a type of porphyria called porphyria cutanea tarda. As you know, there are a great many porphyrias, and all of the porphyrias relate to abnormalities in heme metabolism. Depending where the abnormality is in the heme metabolic pathway, you get a different porphyria. However, porphyria cutanea tarda, or PCT, is the classic dermatological porphyria because it has skin findings. And the reason it has skin findings is because the metabolites that accumulate are photosensitizing. This is a photosensitive disorder. The metabolites back up, they get into the skin and other tissues, and what ends up happening is that skin that is exposed to the sun, classically the dorsum of the hands, develops a photosensitivity, and clinically we see blisters and erosions. So you can see in particular on the left dorsal hand, the blister is already gone, which often happens, as you now know, with blistering diseases, but you see an erosion. And here we see an erosion On your right, there is an intact blister as well. This condition does not heal well. It heals with scarring, and it heals very slowly. There we have a close-up. The face also can be involved, and I think I have a picture here of the top of the scalp. Any place that is exposed to the sun can get blisters in porphyria cutanea tarda. There are two other skin manifestations besides blisters. One is that the patients develop hyperpigmentation. They look like they're getting a tan. And the other is that they develop hypertrichosis. In other words, they become hairier. And a classic place to see this is on the tops of the cheeks. Men and women alike can develop a hairiness at the tops of the cheeks in this condition. And these are all clues that you need to think about porphyria. Now, while this disease is an alteration in heme metabolism, there are certain things that are known to precipitate it. The classic one is alcohol. And classically, we're all taught that if you see a middle-aged alcoholic patient with blisters, you might think about porphyria cutanea tarda. Alcohol is a classic precipitant. However, it turns out that estrogens are also a classic precipitant. And so more and more, we're seeing this condition in women who are on birth control pills or women who are on hormone replacement. Iron may also be a precipitant, and there's a fungicide, hexachlorobenzene, which is also a precipitant of this. Basically, in terms of treating this disease, you try to remove whatever the precipitating factor may be, and then we treat it with the anti-malarial medication chloroquine. And also, we treat it with good old-fashioned bloodletting. This disease is treated by phlebotomy, where we try to drain off some of the excess iron, and that seems to help this condition. However, it is a slow improvement. It can take up to a year to see improvement. Okay, I'm going to move to the next topic now. The next grouping on your handout is hypersensitivity reactions. I don't like to call them drug reactions because we can have a hypersensitivity to drugs, to infection, to a wide range of different things. And the first of these that we're going to discuss is urticaria. Urticaria is the classic type 1 type 1 hypersensitivity eruption. And what that means is that it is mast cell induced. With a type 1 eruption, the mast cells on the patient have IgE antibodies affixed to them. And when the proper allergen comes along, it attaches to the IgE antibody on the mast cell and causes release of the mast cell package. And that package includes a lot of histamine as well as other mediators. And so what you end up seeing in this situation are vasodilatation, which causes the pinkness of the hive. And also you see leakiness of the vessels, which causes the swelling of the hive. Okay, these are immediate reactions in the sense that if a patient has an urticarial reaction to, let's say, penicillin, and you give them penicillin, you are going to get an urticarial reaction probably within a half hour, an hour at the most. Any individual hive will last for less than 24 hours. However, new hives continue to come out over weeks as long as the antigens are present in the system. This is very important because other rashes can look just like hives, but if the urticarial wheel lasts less than 24 hours, then it's urticaria. If it lasts more than 24 hours, it is not. Okay, the next thing we're going to talk about is the so-called morbilliform eruption. I think you can see in this slide that there is sort of a faint pink eruption. People sometimes call this maculopapular, which is not technically accurate. We think of it as morbilliform, meaning measles-like, because it has that look to it. It may be slightly raised, it's pink, and this is what we believe a type 4 reaction. That is, we believe it's lymphocyte-mediated. The reason we believe that is because of the time course. If a patient is given, let's say, an antibiotic that they are doomed to develop a morbilliform rash to, the first time that they're exposed, they will not develop a rash for somewhere between 10 days and 2 weeks. And we believe that's the time it takes to recruit and sensitize the lymphocytes. The second time that they're exposed to the drug, the reaction will come out in 3 or 4 days because they've already been sensitized. Okay, so this is the classic morbilliform drug rash. We often see this to antibiotics. Now I'm going to talk about the spectrum of hypersensitivity reactions that begin with erythema multiforme in its mildest form, move on to Stevens-Johnson, which is more serious, and then move on to toxic epidermal necrolysis, which is the most serious. For this one, I'm going to have to bring the lights way down low, and I apologize for the darkness of this slide, but it was such a classic slide that I just have to show it to you. Erythema multiforme. Still a little bit dark. Well, I'll describe it to you. Erythema multiforme refers to target-like lesions. And classically, they're seen on the palms. So this is supposed to show you target-like lesions seen on the palms. However, they can be seen in other areas of the body too. And we can bring up the lights so I can show the next slide. For example, this is another target-like lesion. So what do I mean by target-like? The classic example is supposed to be like a bullshot with a dusky bluish color in the center and a red rim around it. But it's called erythema multiforme because it can take many forms. And for example, in this one, we see a little blister in the center with a red rim around it. You can see almost any configuration, but erythema multiforme is targetoid. It's got a targetoid appearance. It classically involves the palms, also the soles, but the rest of the body can be involved. And if there's any mucous membrane involvement at all, in order to call it erythema multiforme, it has to be very minor mucosal involvement. Now, we see this very often to drugs. Very often this is a hypersensitivity reaction to drugs, but it's also often a hypersensitivity reaction to infection. The classic infections that precipitate erythema multiforme are herpes and Mycoplasma pneumonia. Specifically with herpes, as you're aware, herpes is a recurrent type of infection. It comes out, it goes back, it comes out, and in patients who have erythema multiforme as a hypersensitivity reaction to their herpes, they can get recurrent erythema multiforme every time they have a herpes outbreak. But we see erythema multiforme to a whole host of things, and the trick is trying to find out what it is that the patient's reacting to, and remove it. And then it's self-limited. It goes away by itself. Now, Stevens-Johnson is the next in this spectrum, and Stevens-Johnson refers to the condition where there is more than minor mucous membrane involvement. And classically what we see are hemorrhagic crusts of the lips and the oral mucosa. This is a classic example of Stevens-Johnson. Now, patients with Stevens-Johnson will very often also have skin findings as well, but it's the hemorrhagic crusts or extensive mucosal involvement that brings us to the diagnosis of Stevens-Johnson. And here we can see this patient also has Stevens-Johnson, and she has extensive cutaneous involvement. It's so extensive at this point that it doesn't really look targetoid at all. They're just big, angry plaques. And this is the same patient as the previous slide, showing that she had these sort of blisters around her around her fingers. This is a much more serious disease. Whereas erythema multiforme is self-limited, this has a mortality of 5 to 10%, even if everything is done correctly. So we need to remove the precipitating agent. We generally do treat with cortisone of some sort, prednisone or otherwise, and even so, this tends to last for 2 to 3 weeks. Now, during that time, what might these patients succumb to? Well, as you can imagine, with the mucosal involvement, very often they're not taking food or fluids very well, and so they have fluid and electrolyte abnormalities. And if their skin is very seriously involved, it's just not an intact barrier anymore, and they're prone to infection. And these are very sick patients. They're febrile, they feel sick. Okay, the next in the spectrum is toxic epidermal necrolysis, and this is by far the most serious. In toxic epidermal necrolysis, the skin becomes confluently red and burns. It almost always burns or feels tender. And then within a short period of time, the skin begins to bubble up and literally sloughs off. And what ends up happening with these patients is that you can have 100% sloughing of their skin. So from a management point of view, it's like having a 100% burn because there is no or very little intact epidermis to provide a barrier function. These patients are tremendously ill. They're febrile. They usually have an elevated white count. They generally have elevated liver function tests. And they're extremely prone to both fluid and electrolyte abnormalities, as you can imagine, and also to infection. This condition, even if everything is done absolutely correctly, has a 25 to 50% mortality rate. This condition is usually, almost always caused by a drug. And the most common drugs are phenytoin, the anti-seizure medicines in general, I should say, phenytoin, barbiturates, Tegretol. We are called to see this very often in the neuro and neurosurgery units. Also, allopurinol can cause this, and several of the antibiotics, penicillins, sulfonamides can cause this. Now, here we have a condition which has an extremely high mortality rate, and it's absolutely essential that you diagnose it correctly because we're going to talk about treatment in a minute, but you want to make sure that you can get the treatment, instituted very quickly. And believe it or not, there's another condition which can look identical to this and which is treated completely differently, and which we're going to talk about in about 10 more minutes when I talk about infection. And the other condition is called staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome looks like scalded skin, and it's generalized, and it can look exactly the same, except staph scalded skin syndrome is caused by a staph infection, and it has to be treated with antibiotics. And this condition is very often caused by antibiotics, and we want to get the patients off of all medications as quickly as possible. So, what do we do to make the diagnosis? We do a biopsy, and we send it for frozen section because we want an answer quickly. On frozen section, as the name implies, we see complete necrosis of the entire epidermis. The entire thickness of the epidermis is lifted up. It's lifted and separated away from the skin, and it's entirely necrotic and dead. This is as opposed to staph scalded skin, which I'll show you in a minute, where the break is way high up in the epidermis. It looks completely different. So you can distinguish toxic epidermal necrolysis from staph scalded skin by a frozen section biopsy. Once you've made the diagnosis of toxic epidermal necrolysis, you have to do your very best to take the patient off of all medications. Because infection is so dangerous, you want to put them into a laminar flow room or a burn unit where infection control is taken care of. We watch their fluid and electrolytes very carefully. Steroids are highly controversial, and most of the evidence indicates that they are not beneficial because they mask infection, and so often infection is the way that these patients succumb. Also, because in TEN you can have eye involvement, you need to have an ophthalmologist involved in the care of these patients too. I want to take questions at the end, but I will just take that one question because it's a good one. How can you differentiate it clinically? Usually clinically, this involves the entire epidermis with sheets of skin coming off throughout the entire body. Usually 100% or close to 100% of the skin is involved. In pemphigus vulgaris, generally we see discrete areas where there was an individual blister which then has lifted off. But there will be involved areas and there will be uninvolved areas as well. And the biopsy will clinch it. Okay. I feel like in terms of hypersensitivity reactions, we're now moving from the sublime to the ridiculous, but I just want to show you what they call a fixed drug eruption because it's interesting and it's a curiosity. Fixed drug eruption refers to certain situations where a patient's exposed to a medication that they're allergic to, and in one area they develop either a blister or a red mark. If you take away the drug, it heals. And if you give them the drug back in exactly the same location, they get exactly the same reaction. And we don't know why that happens. It's not dangerous at all. It's just a curiosity, but it's very classic clinical picture. And it generally heals with a dark mark, which can take a long time to fade. Okay. I'm going to leave the topic of blisters and hypersensitivities, and we're just going to talk about infection for a little while. And I just wanted to very quickly run through some of the most common infections because, of course, you see common things commonly, starting with fungus infections, fungal infections, which we call tinea infections, and beginning with tinea pedis, which means a fungal infection of the foot. Fungal infections on the skin are caused by dermatophytes, which simply means fungus that attacks the skin. And here we see a very bad example of a tinea pedis. Here we see a more classic example. Tinea pedis classically involves the interdigital webs between toes. I want you to know that there is a blistering form of tinea pedis. We can't get away from the blisters, but there is a bullous tinea pedis that usually involves the soles of the foot, and you can see intact blisters, as you can see here. If you open one of those blisters up and you do a KOH preparation, or if you look at it under the microscope, it's teeming with dermatophytes. Here we see a patient who has a fungal infection of the toenails. We call this onychomycosis. Here we have a tinea cruris, which is just a fungal infection of the groin. You can see it's got a classic pattern. Usually it's annular, that is round in appearance with a red, round, scaly border that extends over time. Here, this is a tinea capitis, and I'm just mentioning this. This is usually seen in kids, and generally they will present with a little patch of hair loss or hair thinning, and sometimes the scalp looks very scaly. Sometimes, like in this patient, you really don't see scale at all. If you look closely, there were a few little pus bumps, just a few little pustules, but you always have to think about tinea capitis, because tinea capitis can scar if it's not treated, and it needs to be treated with oral antifungals. Tinea capitis is a fungal infection that can potentially get way down into the roots, and so the topicals just don't get there. You need to treat it with oral antifungals, which is important because I know this slide is dark, but this is a patient who we saw who was not treated, and she has a permanent scarring alopecia, permanent scarring hair loss, simply because her infection was not treated. I just want to quickly show you a tinea corporis. You see some scaly, discrete lesions of the body. And this picture is just to show you how very subtle it can really be. You see just that one little pink scaly area. And the reason I'm showing you this is because 9 times out of 10, when a patient comes in with a little pink scaly area, you're going to think, oh, it's an eczema. But don't forget that it could be a tinea corporis. If you can't tell the difference, there are 2 ways that you can make the diagnosis. One is simply by doing a culture. It does take a few weeks for that to grow out, however, and so the other way is to do a KOH preparation, where you can look immediately under the microscope and see if you see any fungal hyphae. Okay, what have we got here? Whenever you see honey-colored crust, think impetigo. This is a honey-colored crust, and it is caused by either staph infection or by a group A strep infection. And here we have another picture of the same. Now, as I alluded to briefly before, there are certain strains of staph that exude a toxin. And this toxin is called exfoliatin. And exfoliatin can cause the skin to blister up. So let's just say a patient has an impetigo that happens to be caused by one of these staph that make this exfoliative toxin. You can then see, not only do you see honey-colored crust, which may not be 100% clear here, but around the honey-colored crust, you see blisters. And the blisters actually have purulent material in them. They are teeming with staph. Okay? So bullous impetigo is an impetigo caused by a staph that can make a little blister. And I just put down some of the treatments for impetigo. Basically, you just need to cover for staph and cover for strep. Okay. Now I want to discuss the staphylococcal scalded skin syndrome. Let's just say that now a patient has a staph infection, and it happens to be a staph infection that exudes this exfoliative toxin, but it's not on the skin. Let's just say they have an abdominal abscess, or they have an abscess or an infection somewhere at a site that's distant from the skin. And let's say in addition to that, that they're pretty sick. Maybe their kidneys are not working so well, their liver's not working so well, maybe they're older and debilitated or very young. And they've got an infection now with an abscess filled with staph that is exuding this exfoliative toxin. Because they're debilitated, they cannot metabolize and break down this toxin, and the toxin spreads throughout the body. What does it do? It begins to cause the skin to exfoliate. And you can see it's not, in these pictures, it doesn't look as bad as the TEN, but you can see on her palms the skin is truly coming off. And sometimes at the bedside, it is difficult to distinguish from toxic epidermal necrolysis because you see the skin sloughing off. If you culture or do a gram stain of the skin, you're not going to see anything because the staph is at a distant site, and we're just getting the result of the toxin now. So what do we do? Here you can see a close-up of that peeling off. This is the situation where we do the frozen section, because the frozen section will distinguish the two. Here, I think in this picture you can see how that could be very confusing with toxic epidermal necrolysis. But in a frozen section, what we see here is the little bit of pink that you see at the top of the slide is the very most superficial part of the skin. And all of this other area on the left-hand side is the rest of the epidermis, which is all intact. This blister is extremely superficial. It's happening in the granular layer of the epidermis, which is very superficial. And a frozen section can tell you that. so that if you do a frozen section of a patient who's exfoliating their skin and it comes back looking like a very superficial blister, you know that you're dealing with staph scalded skin and you immediately start them on antibiotics. If, however, it's the deeper blister that we talked about before, you try your best to take them off of antibiotics. Okay, I'm afraid we have to bring the lights down again because we're going to talk about herpes now for a minute. And I'm just going to say a few words about herpes. As you know, it's a viral infection. It classically involves the mouth or the genitalia. The reason is simply because that's the areas of inoculation most commonly, but we do see it in other areas. Sometimes the eye can be involved. And what you see clinically are groups of blisters on a red base. We often see it involving the mouth, and this is what we commonly think of as cold sores. The first time that a patient has a cold sore, it can be extremely angry if they have no immunity to it. And even though this is dark, you can see that this poor patient has extremely swollen lips because she's mounting the major reaction to this very bad primary herpes infection. Now here we see an example of the genital form, and I think you can see pretty clearly that there's a group of blisters on a pink base. And here we see another very classic example, a group of ulcers. Actually, the pink base is gone. Maybe this has been around for a couple of days. And this is most likely a recurrence because it's just not that serious. It's just a few blisters. These come and they go. They very often come out in times of stress. The oral herpes can come out not only in times of stress, but also sun seems to bring it out. And we now have treatments for these. There are certain medications that can suppress the herpes virus. Now let's say you see groups of blisters on a red base, but there are many groups of blisters on red bases, and they're extending down what we call a dermatome, or extending along a nerve. We think of herpes zoster. Herpes zoster is a reactivation of the latent varicella zoster virus. So in other words, you can get a herpes zoster in any patient who's ever had chickenpox, who's ever had varicella. Generally, zoster begins with pain. Very often, patients will present to their internist thinking that they're having a heart attack or thinking that they're having a kidney stone or sciatica. And then within a day or two, the blisters begin to develop, and you can make the diagnosis based upon these group blisters. Now, without any treatment at all, it usually goes away in a couple of weeks. With treatment, we can speed things up a little bit. I just want to talk with you about a couple of things having to do with zoster. The first one is if you see a zoster involving the ear. There's a syndrome called Ramsay-Hunt, and it's associated with a zoster of the auditory or facial nerve, and it can be associated with a lot of ear changes, tinnitus, vertigo, but also with a facial palsy. So if a patient presents with a facial palsy and pain, look for group blisters. The other thing I want to mention to you is ophthalmic involvement. If the ophthalmic division of the trigeminal is involved, you need to get an ophthalmologist involved just to make sure that the eye is not involved. And lastly, dissemination. We call zoster disseminated if there are more than 20 blisters outside of a dermatome. And what that means to us is that there's hematogenous spread. This patient is not controlling their zoster infection. And with hematogenous spread, we need to admit the patients and make sure we're treating them aggressively. We also believe that patients who have zoster, whether it's disseminated or not, need a good general workup about a month after it is healed, because sometimes this can come out because the patient is somewhat immunosuppressed from a variety of reasons. So that's just a good idea. It has been associated with lymphoproliferative diseases. Okay, some treatments for zoster. I want to say just a few words about warts. Warts are caused by the human papillomavirus. There are many different types, probably close to 70 now. I just thought I'd show you a few pictures of some hand warts. This is a plantar wart. And I think that's all we need to say about warts. Cellulitis. Cellulitis is usually caused by either staph or by beta hemolytic strep. Usually it presents with a red, warm, tender plaque. It's usually pretty evident. You can see there on the anterior shin. Here we have a big red warm plaque, and you can see the marking and pen because we want to see if our treatment is working or if the cellulitis is extending after we start treatment. Very often we cannot do a culture, and we just have to treat it for what we think it is. That is staph or strep. But I definitely want to mention necrotizing fasciitis, which is, in fact, a medical emergency. This is the so-called flesh-eating disease that people are talking about or have talked about recently. This can be caused either by a mixed infection or it can be caused by a strep infection. And either way, it can be a very life-threatening situation. Generally, it starts with a cellulitis, and very quickly the organisms go deep and they get down to the fascial planes where they can spread along fascial planes and cause a lot of damage very quickly. In particular, strep can spread along fascial planes at an unbelievable rate. You can literally cover from the ankle to the thigh in a day. This needs to be treated with antibiotics, but extremely importantly, it absolutely requires surgical debridement. These have to be surgically opened up, and if they're not, the patient will succumb. There is no way that the antibiotic is going to get into that necrotic tissue at the fascia unless the area is completely and widely debrided. This is just another example. You can see what was once just a red plaque has turned into these necrotic, hemorrhagic blisters, and the patients are extremely sick. You have to think about it. We can always do a biopsy and see strep very deep, and that gives us our diagnosis if there's any question. Okay, I'm going to say a couple of words about syphilis now. Basically, primary syphilis classically starts with a chancre. Chancres for syphilis are called hard chancres. They're classically non-tender, although sometimes they don't read the book, sometimes they are tender a little bit, and they can be associated with adenopathy, which is also non-tender. The important thing you need to know about a chancre is this. The average time of onset of a chancre is 3 weeks after an exposure. It can be anywhere between 10 and 90 days, but the average time of onset is 3 weeks. The average time when the blood test turns positive is 4 weeks. So if you see a patient and you're thinking it's a chancre, a blood test is not helpful. You need to do a dark field examination of the chancre, and you can see the spirochetes, treponema pallidum, and then you treat. Now, let's say you miss it and the patient goes on to secondary syphilis. Secondary syphilis classically appears 6 to 8 weeks after the chancre, and what you classically see are over the body these sort of oval, salmon-colored patches. The palms and the soles are involved. That's very important because shortly we'll talk about a condition which can look exactly the same, but the palms and the soles are not involved. So the palms and the soles are involved in secondary syphilis, and at this point the blood test should be positive. Let me just say one quick word about syphilis with HIV. This is a very controversial topic right now, and there's a certain amount of controversy about how aggressive you should be in terms of spinal taps, because apparently patients with HIV infection can very quickly go into tertiary syphilis with CNS changes. It's a controversial issue, but some people do believe that if you see syphilis in an HIV-positive patient, you should automatically get a spinal tap. Okay, now we're going to talk about scabies now. Scabies is caused by the human mite, which is called Sarcoptes, S-A-R-C-O-P-T-E-S, scabii. It causes extremely itchy bumps in certain classic locations. And if you see extremely itchy bumps on the penis and the scrotum, the first thing you should think about is scabies. Okay? Other places that can be involved classically are the breast, especially the areola, The axilla is often involved. And very often the interdigital webs of the hands. Now, usually what you see in scabies are either itchy bumps or scratched bumps because it itches so much. But what we love to see are little furrows or burrows where the mite has actually crawled under the skin. And in this slide on the dorsum of the hand, you can see linear burrows where that mite has sort of crawled underneath the skin. If you see a burrow like that, you can make the diagnosis instantaneously because all you have to do is scrape it and look at it under the microscope, and you will see, well, let me get you a picture of it here. One of these guys, one of these little mites. And this is a great slide because not only does it show the mite, it shows the eggs too. Very often, they say in a healthy person, you can have a terrible case of scabies, but you'll only have an average of 11 mites on the whole body. So sometimes you don't scrape a classic spot, and you have to look for debris that the mite has left behind, like eggs. Okay, we have to do this again, I'm afraid, with the slides. I just have to bring the lights down again because I want to talk about meningococcemia, which is a tremendously important topic to be comfortable with. Classically, patients with meningococcemia present with as they say in the textbooks, an upper respiratory infection, which is very brief. The problem is at the very next stage, they develop fever and mental status changes. So very often you do not have the luxury of hearing about their upper respiratory infection if they even had one. So when we see a patient who presents with fever, mental status changes, and a rash, we immediately think meningococcemia. The rash is the rash is moderately classic. What you're supposed to see are petechiae, which are non-blanchable purple areas of the skin. And let me see, here you can see a good petechiae in the center of those. Non-blanchable purple areas of the skin which get sort of a smudged look to them. And given a bit of time, the centers become vesicular and necrotic, so that they have a center that gets sort of a gray, slate gray, necrotic look to it. And they can be quite widespread. You don't always see signs of meningeal irritation in meningococcemia because sometimes it's so acute and so fulminant that you just don't have time to see those changes. So if you see a rash with fever and mental status changes, you need to immediately think meningococcemia. Now, of course, what do? We do a spinal tap and we look to see there should be increased CSF protein and decreased glucose, and you can do a gram stain to actually see the organisms, and then we treat immediately. So even though you're always supposed to think, oh, that one is too dark again. Even though you're always supposed to think meningococcemia, there is a differential that needs to go through your mind. The other classic one is just other bacteremias. Staph bacteremia, any bacteremia can present in a similar way, and certainly if a patient is septic enough, they can have mental status changes. The classic slate gray necrotic centers are more characteristic of meningococcemia, but they can be seen with other bacteremias. Also, endocarditis. Just this weekend, I saw a patient who had 3 valves replaced, a fever for a week and a half, and scattered all through her body lesions that looked like this previous one, just like this, and I'm sure that she has a bacterial endocarditis. So you need to put the whole picture together. Other things that can be thought of in this situation are nonspecific viral diseases, as well as hypersensitivity vasculitis can look similar to this. Okay, I just want you to know and remember that not everything that is purpuric is meningococcemia or a major infection. You have to keep in mind that, once again, common things are common, and this is just an example of senile purpura. We see this all the time in elderly patients who have fragile connective tissue, fragile blood vessels, and in areas of unbelievably minor trauma, they can end up with large purpuric areas. These patients do not have any fever necessarily, unless it's related to something completely different, and they're well otherwise. And there we just have a couple of more examples of that. Okay, I think we're up to the second carousel now, where we're going to talk a little bit about tumors and pigmented lesions. And while we have this 2-minute break, does anybody have a question? 30-second break while they switch the slides. Let me just say a couple of words while they're switching the slides about pigmented lesions, because it's good to have a little framework in your mind when you're looking at these pigmented lesions. Pigmented lesions come in all sorts of shapes and sizes, and we're going to talk about them right now. But the thing to keep in your mind when you're looking at a pigmented lesion is symmetry. Is this lesion symmetrical or is it asymmetrical? And they also say you're supposed to look at the border. Is the border regular? You're supposed to look at the color. Is the color regular? You're supposed to look at the diameter. Is it nice and small? Classically smaller than a pencil eraser. But symmetry, if you keep that in your mind, keep in your mind that nature likes symmetry. It's extremely helpful because the benign pigmented lesions tend to be symmetric, and once a malignancy has occurred, the growth is out of control and they tend to be asymmetric. So we're going to start with what we call a junction nevus, which is a completely benign lesion. Within reason, nature's not perfect, but within reason, this is a symmetrical lesion. You bisect it, one half looks like the other half. And junction nevi are called junction nevi because the nevocytes, the cells that make up the mole, are found at the junction between the dermis and the epidermis. They're completely benign. Here we have a compound nevus, completely benign. Once again, it's totally symmetric. One half looks exactly like the other half. We call this a compound nevus because some of the nevocytes are at the DE junction and some of them are down in the dermis. So it's compound. There are nevocytes in both places, but it's completely benign. Here we have one. Now it looks very unusual, right? But it is totally symmetrical. This is a benign lesion. Here we have another one. This is called a dermal nevus, intradermal nevus, because the nevocytes are all down in the dermis. It's skin-colored, it's completely symmetrical, and it is completely benign. Here we have a halo nevus. If you see a symmetrical halo of lightness around a nevus, if it's symmetrical, you don't have to worry. It means that it's a halo nevus. And it means that the body, the lymphocytes are destroying that nevus for one reason or another. But if it's a symmetrical halo, it's benign. If you were just to see a white patch at one corner of that mole, you'd feel differently about it. Okay. Now this one is not symmetrical. This one has an irregular border. It's got irregular color. It's very irregular, and this patient presented in the 9th month of her pregnancy with this on her body, and very fortunately, this was a melanoma in situ. In situ. Melanomas start with an in situ phase, which means that it's only in the epidermis, and if it presents at the stage where it's in situ, only in the epidermis, without any involvement of the dermis, there is then a 100% cure if it's properly excised. We're going to talk about treatment and prognosis in a minute. Here we have a true bona fide melanoma. This was not in situ. Here we have another melanoma. You can see it's very asymmetrical and irregular. This patient presented for something completely unrelated. We found this, and unfortunately he succumbed to this melanoma. Here we have what we call a nodular melanoma at the temple of this gentleman. This one is possibly more symmetrical than the others, but you can see it's large and it is somewhat irregular. Melanomas generally fall into several different categories. The most common melanoma is called the superficial spreading type of melanoma. It accounts for about 70% of all melanomas, and that's the kind of melanoma we most want to see because it has an in situ phase, an epidermal phase, that can last for 6 months to a year. So it gives us plenty of time to find it and get it out when it's at the 100% curable phase. The next most common kind of melanoma is called nodular. That accounts for 15% of melanomas, and that's what this kind is. This kind of melanoma appears and it immediately invades, so that there's really not that same time frame. And then the other two kinds of melanoma are the acral kind, which is usually on the feet or the hands. That unfortunately has a very high mortality. And then there's also something called the lentigo maligna type, which is generally seen on the sun-exposed skin of elderly people, and that has a very good prognosis. Basically, we divide melanomas up into 3 stages. Stage 1 means just the skin. Stage 2 means lymph nodes. Stage 3 means mets. And with regard to the prognosis, it all has to do with level of depth of invasion. If it's a superficial melanoma, we can remove it and do very well. If it's invaded deeply, we don't do so well. I wanted to show you this slide because not everything that's pigmented and irregular is a melanoma. These have a greasy, stuck-on appearance. These are seborrheic keratoses, and I like to think of them as an overgrowth of the top layer of the skin. They just represent a thickening of the top layers of the skin, epidermis and cornified layer, and they're completely benign. There's a close-up of one. They have a very crusty, greasy, stuck-on appearance. Okay, we're going to spend a few minutes now talking about precancers and skin cancers other than melanoma, starting with actinic keratoses. Actinic keratosis refers to an area of the sun which is scaly. That's the keratosis, and actinic meaning caused by the sun. They are pre-skin cancers, but the vast majority of patients who have these don't actually develop a skin cancer. And you can see here on the nose there's just that scaly red patch. If you see a scaly red patch in a sun-exposed site, think about actinic keratoses. Here we have a hand that's full of them, filled with scaly red areas. Okay, we're going to move on to the next slide because that one's too dark. Given enough time, these actinic keratoses can turn into squamous cell carcinomas. What you need to know is 75% of all squamous cell carcinomas that happen on the skin are sun-induced. Sun-induced squamous cell carcinomas do not behave like squamous cell carcinomas of the lungs. They have a very low metastatic rate, somewhere between 0.5%, 1%, maybe 2%, but very, very, very low. So if we can find them and treat them quickly, we can cure the patient in most cases, and that's what we need to keep in mind. The one exception, by the way, to that rule is squamous cell carcinomas of the mucosa, specifically the lip, where there's a higher metastatic rate, maybe somewhere between 10 and 20%. The next kind of cancer is basal cell carcinoma. Basal cell carcinomas classically have a pearly, raised border with a central crust. Sometimes you see a little broken blood vessel on it. It is the most common of all cancers. They do not, for all intents and purposes, metastasize. They stay locally, a problem locally, and they simply need to be removed. Okay, that's basal cell. I wanted to say a few words about Kaposi sarcoma because we see so much of it now. Kaposi sarcoma can be seen in an immunosuppressed population and also can be seen in an elderly population. In the immunosuppressed population, we include both AIDS and also people who are immunosuppressed from lymphoproliferative diseases, chemotherapy, and so on. And what you see are these bluish or brownish nodules. Sarcoma is a misnomer. It is probably a neoplasm of endothelial cells, both lymphatic and blood vessels, small blood vessels, capillaries basically. And it's multifocal, as you can see. Here you can see it's just this bluish plaque-like discoloration. You need to think about it, and then the diagnosis is made by a biopsy, This is just a picture of the classical Kaposi's in an elderly man of Mediterranean origin. And that's just the classic Kaposi's, which can be indolent and last for a very long time. And you can see sort of the purple-red nodules, and there are areas of breakdown. Okay, Let's talk about the group of diseases called papulosquamous, beginning with psoriasis. Psoriasis has a classic description: silvery scale on a red base. If you see silvery scale on a red base, think psoriasis. It usually involves the knees and the elbows, rarely the palms, sometimes the scalp. Psoriasis can cause nail changes, including pits. You can see here little pitting. And general dystrophy. Sometimes the nails get yellow. Sometimes they lift up. We call that onycholysis. It's not unusual. Okay. I'm going to go through a description of several of the eczemas now. Eczema also means dermatitis. They're the same thing. And I want to distinguish them for you in your mind. We start, okay, here's a patient who just has some dry skin. And here we have, okay, some dry skin on the arms. And what happens in time is that we can develop what we call osteototic eczema, which is eczema simply on the basis of dryness. The skin gets so dry that it just breaks down. And we get osteototic eczema or osteototic dermatitis. And here we have a few other examples of it. You can see it's red, it's scaly. The skin looks fissured. We classically see this on the lower extremities because they tend to be drier. We see it often in the wintertime. It literally is just cracking and inflamed from dryness. Now that is in comparison with the next type of eczema, which is atopic or allergic type eczema. Atopic eczema is usually seen in what we would call atopic families. And in those families we see asthma, hay fever, and this specific type of eczema called atopic eczema. Classically, see, these patients have a lot of IgE floating through their system, and specifically it's IgE to staph. So they just react in an allergic way to the staph that's on our skin, and they get very itchy skin. Classically, they get these red, itchy plaques in the flexures. Like here we have in the antecubital flexure. Here we have another picture of the same. Here you can see on the legs, it's all scratched up. It itches tremendously. You can see the scratch marks on these patients. And here we see not only scratch marks, but the skin is actually thickened from so much scratching. You can make this diagnosis by taking a history, basically. Is there any other atopy in the family, any asthma, any hay fever? And then we treat by removing a lot of the things that cause allergy to these patients. Okay, I want to say a few words about seborrheic eczema or seborrheic dermatitis. We don't really know what causes seborrhea. It's a chronic condition where we see redness and scaling in certain classic locations like the nasolabial folds, the eyebrows, around the ears, and the scalp. Here we have the ears. I want to briefly mention stasis dermatitis. Stasis dermatitis begins, we think, with venous insufficiency. Because the venous system isn't working well, there's venous hypertension. Fluid and formed elements leave the vessels and get into the skin. The formed elements, like the blood cells, leave hemosiderin, which gives you the dark spots. Proteins surround the vessels, causing fibrin cuffs and preventing oxygen exchange so that the tissue becomes hypoxic and it breaks down and it has a hard time healing. Contact dermatitis. There are two kinds of contact dermatitis. Sometimes you get a contact dermatitis just from irritation. Something that's irritating has come in contact with the skin and it's irritating the skin. And sometimes you get an allergic contact dermatitis where the patient is actually and truly allergic to the thing that's irritating the skin. In an allergic contact dermatitis, what you see is well demarcated. You only see the rash very precisely where they came in contact with the problem. In this particular case, it was poison ivy, which classically leaves these linear sort of blisters because the patient brushes against a leaf. Now, just to leave the eczemas but discuss the last of the papulosquamous or scaly eruptions, I want to mention pityriasis rosea. Pityriasis rosea is the condition that I referred to before that looks for all the world like secondary syphilis. It's got oval, slightly scaly, salmon-colored patches over the body. How do we distinguish? First of all, it never involves the palms, so you check the palms. Number two, pityriasis rosea classically begins with what they call a herald patch, which means that before the general eruption begins, you see one large patch about a week before, and that's the herald patch. And of course, we always get a VGRL to make sure that it's not syphilis. Just a couple of words about decubitus ulcers. I just want you to know the way that we refer to them. Stage 1 is non-blanchable redness. Stage 2 is very superficial breakdown, just involving the epidermis and maybe the very most superficial dermis. Stage 3 means full thickness of the skin, but not to the fascia yet. And stage 4 means all the way through to bone or muscle. Okay? What causes a pressure decubitus? Well, of course, pressure. But in addition to pressure, there are several other things you need to remember. Decubitus ulcers are caused by pressure. They're caused by shearing forces. If the patient is slipping down in their bed, if the head of the bed is raised and they're slipping forward, those shearing forces can cause a decubitus ulcer. Friction, rubbing can cause a decubitus ulcer, and also moisture from incontinence can cause a decubitus to begin to develop in the right setting. Not only urinary incontinence, but fecal incontinence is implicated. So we need to correct all of these issues when we see a patient who has a decubitus ulcer. I'd like to say a few words about nails. I just want to discuss a couple of things. The first is acute paronychia. With acute paronychia is an infection, usually a staph infection of the area around the nail. We see it all the time in patients who are getting manicures. And sometimes you actually see a pus bump. Sometimes it's just red and tender. We generally culture these, but we always cover for staph. And you do want to make sure that you treat it quickly, because if the swelling gets to be great enough, remember that this is a very enclosed space. If the swelling gets to be great enough, you can actually impair the blood supply to the distal tip of the finger. So if it's too inflamed, we can have problems. We try to decompress it, drain it, soak it, and treat it with antibiotics. Okay, we have the same darkness problem, but I think here you can see, I want to show you clubbing. Clubbing refers to a distal bulbous enlargement of the fingertips. And while it is sometimes seen in a familial setting, it's classically seen in patients who have some sort of a chronic lung problem. It can be emphysema, bronchiectasis, tuberculosis, but if you see clubbing and it's not a familial situation, you better look into the lung situation. Sometimes it's a cyanotic heart disease as well. I just want to mention that there is a condition called hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy looks just like clubbing, except for there are a few key differences. One is that there's actually tenderness. Clubbing is not tender, but hypertrophic osteoarthropathy, the distal finger is tender. And there's also periosteal thickening of the distal phalanx in hypertrophic osteoarthropathy, and also there's often gynecomastia. And hypertrophic osteoarthropathy is associated with lung CA, lung carcinoma. Okay, let me move on to the next topic, which is hair. I want to discuss a few different hair conditions, beginning with alopecia areata. A patient presents with oval or round patches of complete hair loss. All of a sudden the hair has just simply fallen out. Sometimes it can be very extensive. This patient had really quite extensive involvement. Sometimes it's just little coin-shaped patches the size of a quarter or so. And sometimes it becomes what they call totalis, where the entire head is completely involved. There's also a universalis type, which involves all of the hair of the entire body. We believe that this is an autoimmune type of disease where the body is fighting against the hair follicle, but we really don't understand it very well. I will tell you that these are the fingers of the man that we saw just before this. It can also involve the nails. With abnormalities of the nails become dystrophic. So it is definitely a systemic condition. Okay, here we have a patient who has a different condition called traction alopecia. Alopecia simply means hair loss. Traction alopecia comes from chronic pulling of the hair, so much so that the roots are actually destroyed. And we very often see this in people who wear their hair extremely tightly braided or extremely tightly pulled. This is a permanent alopecia. It's a permanent scarring alopecia. Once you've destroyed the roots from pulling, they're not going to come back. Okay, this is the next topic on your list. It's called telogen effluvium. Telogen refers to the resting phase of hairs. Hairs go through a growing phase and they go through a resting phase. The resting phase is called telogen. If a patient undergoes a tremendous physiologic stress, let's say surgery, or let's say they deliver a baby, or a tremendous infection, sometimes many of the hairs will go into a resting phase all at the same time because the body is stressed and it's shutting off non-essential functions like hair growth. So all of a sudden, all the hairs go into the resting phase. And a couple of months later, when the new hairs begin to grow, they push out the old hairs, and all of a sudden, over a period of a month or two, an enormous amount of hair can be lost, and you can literally get this kind of thinning. I have another patient here. This was a postpartum patient. These hairs will grow back. The problem is that the hair follicle is way down underneath the skin, and the new little hairs haven't reached the surface yet. So you go through a few months where you just see an enormous amount of hair fall out, but the new hair hasn't come in. It's the history that makes the diagnosis in this case. Now this looks for all the world the same way, but the history is different. This is androgenetic alopecia. This is what we think of as male pattern or female pattern baldness. And this is simply a situation where, because of a combination of your genetic makeup and hormones, androgens, you begin to have a slow loss of hair that often begins in the 20s or 30s and just continues throughout life. And here we have another example of that. And there we have an example of that trying to be corrected with hair plugs. Okay, I just wanted to say a few words about a couple of different kinds of benign growths or nodules that you can see in the skin. I'm starting with gout. Gout is caused by chronic elevated uric acid levels. And what happens is, after the uric acid levels have been elevated for a certain period of time, uric acid begins to deposit in the joints. And to begin with, we get joint pains. And then over time, it begins to deposit in the skin. And we get these chalky subcutaneous masses that we call tophi. And they are simply sodium urate crystals that have deposited in the skin. And there we see them. They're completely benign, but they're definitely gout. Okay, I wanted to show you these. We see them every day. They're skin tags. They're also called acrocordons. I have them on your sheet as acrocordons, which is a more accurate name for them. They are completely benign, and contrary to popular opinion, they're not associated with internal malignancy or anything like that. They're just a personal and possibly familial tendency. We may see these a little bit more frequently in obese patients, possibly a little bit more frequently in diabetic patients. Okay. I made a mistake on your handout, and I forgot to include this lesion, which I want to talk about next, and that is cysts. I want to discuss cysts. People talk about sebaceous cysts. Dermatologists divide up the so-called sebaceous cyst into two types. One is the epidermoid cyst, and the other is the pilar cyst. The pilar cyst is also called a tricholemal cyst. And basically, it depends where the cyst originates from. If it originates from the epidermis, it's an epidermoid cyst. If it originates from the hair follicle, it's a pilar cyst. Either way, what is happening is that either skin epithelium or the hair follicle epithelium invaginates underneath the skin and makes a little pocket underneath the skin. Very often you can actually see the little punctum connecting it to the surface. And what happens is that that skin keeps on making skin cells and oils, sebum, everything it's supposed to be making, but now it's in a little pocket. And it makes these cysts underneath the skin. They're completely benign. The problem is that if they do not have a punctum connecting them to the surface, all you see is a nodule, so you can't be sure that it's just a benign cyst until you remove it. However, both epidermoid cysts and pilar cysts are completely benign. 90% of the cysts that we see on the scalp are pilar cysts. They come from hair follicles, but you really can't tell until you remove them. And this was just an example of one of those cysts. And you can see they can get to be quite large. The next thing that's listed on your handout I just wanted to include by way of comparison, and that is the so-called digital mucus cyst. These are little growths that we see on the digit. They're not firm like the epidermoid cyst. They're very squishy and soft. They are one of two things to make them up. One possibility is just a little collection of mucopolysaccharides, in which case they're completely benign and we just drain them out. And the other possibility is sometimes they're a herniation of a joint sac. And so if you see those, you don't need to worry. Okay, and last but not least, I wanted to say a couple of words about hemangiomas. Hemangiomas are benign collections of blood vessels. There are two types. There are capillary hemangiomas and there are cavernous hemangiomas. This is an example of a capillary hemangioma. Capillary hemangiomas are also called strawberry hemangiomas because they have that bright red strawberry sort of look about them. And they're just made up of capillaries, as the name implies. Generally, these appear early in life, like the first few weeks. And then, during the child's first year, they enlarge, and people get very concerned about them because they're enlarging and enlarging. But by the end of the first year, they generally stop enlarging, and then they involute. And each year, they involute more and more, such that by the time the child is 9, 90% of them have completely involuted. So they are completely benign, but they certainly can be very scary when it's happening. The cavernous type of hemangioma is a little bit different. This usually appears in infancy, and it persists. It grows with the patient, but it does persist. And this is due to deeper dermal vessels, and because they're deeper and more blood-filled, they have more of a nodular, purplish, appearance. But they are also completely benign. And of course, biopsying one of these is quite difficult because of the blood involved. Okay, that really is everything that I wanted to say today about dermatology, and this concludes the dermatology lecture. In a couple of minutes, I'll take any questions.